are three things that all addictions have in common. A problem, whether it's physical, psychological, or just a social problem. A connection to reward, whether this is positive reinforcement like pleasure or euphoria, or negative reinforcement like relief from discomfort like anxiety. And at another level of analysis, a connection with the neurotransmitter dopamine. We will circle back around to dopamine in Lecture 5. I don't want people new to the biological level of analysis to think that it holds the answers when it just gives us another level of description of the situation or processes of addiction. In assessment, we're looking for these three universal things. These three things that all addictions have. What follows is mostly taken from lectures 2, 3, and 4 of my abnormal psych videos. These are just preliminaries to introduce some clinical concepts we use to understand addictions that we also happen to use to understand any psychological disorder. Here is someone you may have been introduced to before. Her case is found in some Health Canada literature and in at least one popular book on addiction, and I occasionally use her case in my other courses. This is a case taken from the book Biology of Desire by Lewis, who, along with Gabor Mate, is our current Canadian voice on addictions issues. Natalie was a liberal arts student. She was outgoing and from a small town. She started experimenting with a few different drugs, all of which were fun, but none of which were exactly life-changing. She reported that these drugs would help her push down the anxieties of life and quiet a kind of general hum of fear and anxiety that she had, particularly fear of failure. It wasn't until she tried opioids that she actually experienced a drug-induced vanishing of these anxieties. So when she was high on opioids, this anxiety that she could previously only kind of push down and ignore disappeared and melted away. Despite being successful in life, work, love, school, she still felt that she needed this high. And at first when she was using, she could go even weeks without using, so there wasn't much reason for her to think that she was getting addicted. But eventually she started to get withdrawal symptoms, stomach pain and breathing issues if she went those few weeks. So that's withdrawal, and she was also starting to experience tolerance, i.e. needing more of the same substance in order to get the same level of high. And as tends to happen with opioids, things like OxyContin are quite expensive. You can get stuff that's harder for cheaper. So Natalie switched to heroin. So now she was a heroin user. She wasn't injecting yet, but she was a heroin user, and through this she maintained her school grades, her employment, and her romantic relationship. But as tolerance and withdrawal increased, she sought more efficient ways or more effective ways of using. So she went from smoking to snorting, and then she saw a friend of a friend injecting heroin, and she said, "Show me how to do that. I want to know how to do that." And she said that the first time she injected heroin felt like the first time she got high on OxyContin. In other words, once again, everything melted away. So now she's an injection heroin user, and she reports that every day, more and more of reality seems to fall away, such that the only thing that's left is a focus on her next injection. At this point, she reports she can't really go more than a day, maybe 2, without shooting up because of the withdrawal. Obtaining the substance became the only thing she could think about. She lost sleep because she was constantly checking her phone rather than sleeping in order to see whether her dealer or her boyfriend could get the substance. And she notes a big existential turn, as well as her view of herself changes from a quiet, bookish, successful student to, in her words, the raunched out chick playing the blues in the bus station, living on the edge. A life of craving and desperation. So she discusses this issue with her housemates, and they agree that they have a drug problem. But this doesn't actually lead to change. The change came when the police were responding to a hit and run that one of their friends committed with her roommate's car. So they were engaged in a hit and run, and then drove back to the house. The police responded to the call. They found the car. They looked in the window. They saw the drug paraphernalia, arrested the lot of them for possession. Natalie ended up with just 1 year of outpatient treatment. But this was group therapy with a group of individuals who were much older and mostly alcoholics. In other words, Natalie didn't identify with them at all. You're supposed to be able to connect and understand and learn from your group members, and Natalie was just not connecting. This is quite the failure on the part of the outpatient treatment because it's supposed to be individualized, and it was clearly not the right place for Natalie. She took back up the heroin habit and faked her urine tests. Her habit ramped back up to injecting heroin every day. She got caught again, but got let off with a warning. She got caught again, and they sent her to a 30-day rehab in a building with other individuals. She again didn't identify with these individuals. After the 30 days there, they followed up with her as an outpatient as well, and things were looking good because she got a job, but she began using again despite being the subject of follow-up with probation officers. At this point, she says that she was taking heroin just to feel okay. It wasn't for the high anymore, it was that when she took heroin, that was the only time she felt okay. But of course, it's the withdrawal symptoms that require her to take heroin in order to feel okay, so she's stuck in a vicious cycle. On one occasion, she slept through an appointment she was supposed to have with her probation officer, so the probation officer came to her place of residence and said, "Are you using drugs?" And she said no, and said, "Okay, well then you probably won't mind if I look in your underwear drawer," and there were drugs there. So this time they threw the book at her. For possession of this heroin, she was sentenced to 9 months of maximum security prison. Do not pass go, do not collect $200. She was taken directly from court to prison. And despite how long and many chaptered this tale has been so far, this is the first time that Natalie's family learns that she had been involved with drugs. So at this point, we can pause and go through our clinical description terms again. What's being described here? Natalie thinks obsessively about injecting heroin and is unable to remain abstinent. It is the present tense, and it appears to be what's wrong, so it kind of looks like the presenting problem. Next, heroin withdrawal is associated with increasing abdominal discomfort, which could exacerbate Natalie's anxiety over just being okay. So what's being discussed here is what could be expected to happen generally. The reference to Natalie is just a could. It's not an actual prediction that's being made, so this is just the course. This is what we expect, or tend to see, with heroin withdrawal in general. Next, roughly 0.37% of the population are opioid addicted in a given year. So this is the yearly prevalence. Next, with the help of family and forced abstinence, recovery can be accomplished. Likelihood is fair to good. Here's your subjective judgment types of words, fair, good, that indicate we're talking about the prognosis. Next, after experimenting with other drugs, Natalie discovered that OxyContin was the first to completely quiet her general everyday concerns. Note the past tense. This is telling the origin story of Natalie's problem. It is the etiology. Finally, we have seen more cases of opioid abuse so far in the current year than any other year on record. The language here isn't terribly precise, but it's clear enough to know that we're talking about the incidence. So these are aspects of the clinical description, which is an aspect of the clinical assessment, your systematic evaluation, and where you can, measurement of biological, psychological, and social factors. Something we might do at each of these 3 levels. At the biological level, we could do something called a naloxone challenge test. Essentially, if administration of naloxone sends you into withdrawal, that means you had opioids in your system. We want you to be able to pass the naloxone challenge test before we give you other types of supplemental or replacement opioids. So if we're starting you on methadone treatment or buprenorphine
or naltrexone, which, if you take it, it should prevent you from experiencing the high of opioids. But in order to get our dosage right, our calibration right, for methadone, buprenorphine, or naltrexone treatments, we need to make sure we're starting from the right baseline so that we don't overdose you generally and underdose you in terms of what you need moving forward. There's also, of course, urine tests to see if there's any in your system. On the psychological level, we could do a structured clinical interview for the DSM. Called a SKID assessment, the point of which is to walk through the diagnostic criteria that we talked about last lecture and see whether Natalie qualifies for a opioid use disorder. And we could also do a SKID assessment for diagnosis of potential anxiety disorders, and this would let us look at diagnosis proper. It would let us look at the severity, mild, moderate, or severe, and might help us look in other places, for example, focus in on her anxiety, in order to see how we might need to individualize her treatment, because we do need to individualize her treatment. There are also various ways that we could assess the social level or social dimension of Natalie's experience. We could ask about or speak to her peers, request that she engage with drug court, see what kind of support she actually needs, and try to determine what change in context she needs that she hasn't been getting yet. The famous example with addictions is the heroin-addicted Vietnam veterans who, when they came back to the U.S., something like 90% of them simply recovered. They went through withdrawal and they worked through it. It was such a change in context from fighting in the jungle to being back home, maybe because they couldn't find heroin, maybe because the motivation to take it had changed. Whatever the reason, the big change in context was apparently enough for most of the Vietnam veterans. And the actual conclusion of Natalie's case was that the change in context worked for her. She had the 9 months of forced sobriety, during which time she made use of the prison library to teach herself meditation as a way of dealing with her anxiety. And when she was released, she went to live with family in a place where she had never used before, where she had support. And she reports that she only went back to trying pills once and has been sober since, and she now works helping other individuals get through their addictions.
Returning to the concepts, here are some more case file excerpts. Pause and write down your answers. Mine are at the end of this video. When doing clinical assessment, we do not get to only look at the few things we happen to specialize in, like addictions. As we will see in the next lecture on co-occurring disorders, the client in front of us typically has a lot more than an addiction going on in their life or in their biology. So, the general guidance and mental status examination basics will be what we need to start assessment of clients. Here are those basics.
Most assessment is rather obsessed with diagnosis, which is fine if you take the traditional meaning of diagnosis, which is profound understanding. But if you take it to just mean labeling someone or labeling their problem, then you could easily make a case that focusing on diagnosis might distract you from what the client actually needs. Connection, insight, understanding, working through, reflection, comfort, recontextualization. In other words, there's lots of good reasons to criticize the rather monomaniacal focus on diagnosis in clinical assessment. Just keep in mind that people mean different things when they say diagnosis. I have evolved since my undergraduate days to be more charitable towards use of the term, and I tend to assume now that when people say diagnosis, they just mean an understanding of the case in front of them, an understanding facilitated by the appropriate labels. Because, as any English professor will tell you, if you can't find the right words, then you don't understand what's in front of you. So let's start with the first meeting, and your first task in the first meeting, which is to conduct a mental status exam. 5 sections. In your first meeting with a client, you will be assessing, for the sake of your records, and in order to have the most objective perspective of the individual and their interaction with you as possible, their appearance and behavior, their apparent thought processes, their mood and affect, mood being how they describe themselves and affect being their apparent observable emotional responses, their intellectual functioning, and what we fancily call sensorium, i.e. whether they know where they are and have some basic self-perception and awareness. Now, depending on your goals and depending on your discipline, you will have different versions or forms or breakdowns of the mental status exam. I have to show you at least one slightly different version in parts so that you know what to expect when you actually get into the real world, and whatever company or place or discipline you're working for has a different version of the mental status exam. This is so that you're not surprised. This is a more clinical/medical mental status exam from this psychiatric interviewing textbook I have, and I actually prefer its approach because it splits up thought processes into different subcategories. So first it has appearance and behavior, but then it splits thought processes up into 3 categories. So you have your speech characteristics and thought processes. Then you have thought content. This is where we could explicitly and individually evaluate things like delusions. And then you have perception, where we can individually and singly evaluate things like hallucinations. Then you have mood and affect. And whereas Barlow's abnormal psychology text has intellectual functioning and sensorium as separate categories, the psychiatric interviewing text puts them in the same box as sensorium, cognitive functioning, and insight. And of course, if we were doing a neurological type of mental status exam, we would likely split this category up even further into various subtypes of intellectual functioning, and likely various tests to evaluate sensorium and things like delirium as well. So the actual structure and content of the mental status exam varies from place to place, but these 5 categories do seem to cover pretty much everything. I just like how the psychiatric approach better splits up the thought content. So before we go any farther, the mental status exam exists to help us record as faithfully and accurately as possible the individual when we first meet them. Memory is malleable, and we are liable to make errors of recall that fit with whatever is currently in our minds. So recording the individual's state and appearance as objectively, as faithfully as possible is vital to avoiding all kinds of bias, including false memories later on. These observations are not necessarily geared toward diagnosis. Sure, that's the overarching goal in general, but we're not making every observation with the idea that it is going to be pertinent to some sort of diagnosis. One of the items on many of the checklists that try to make the mental status exam process easier for clinicians is whether the person had a cane or not, so whether they used some assistive walking device. Now, we don't know whether or how the fact that someone used a cane in their intake interview could be useful to us, but having it recorded as something that occurred could be useful in case that variable changes somehow. And we can trust the observation much more if it's in our actual notes rather than just we think we recall that they had a cane at the first meeting, but they don't now. So the mental status exam gets us to look carefully at what's in front of us, gets us to record what's in front of us so that we don't screw it up with our memory later. And not everything we write down is intended to be relevant or is expected to be relevant to later analyses or diagnoses. The best way to break down the mental status exam is to use one of the scaffolding checklists that some individuals use for their mental status exam procedure. In order to evaluate appearance and behavior, some people go through and they actually check off or circle from the following lists what is relevant or what is present. So here are some checklist examples for assessing appearance and behavior. Psychomotor activity. Is the individual engaging in a normal amount of psychomotor activity? So, maybe, I don't know, once in a while, shifting in your seat or tapping your foot once in a while? Or is it overactive? So are they constantly moving, hyperkinetic, or underactive? Are they just still as a statue? We don't know whether this is going to be relevant to anything later on. If they're overactive, well, maybe they're going to be found to have hypomania later on. Maybe. The checklist just gets us to look and to record so that our memory later on will not be fooled into putting something there that fits that wasn't actually there to begin with. Next, apparent age. Does the person seem as old as they chronologically are, or do they present as younger or older than they actually are? Is the person overweight or obese or underweight? How is their grooming? Are they appropriately dressed for the meeting, or is it inappropriate? Inappropriate might be sweatpants, inappropriate might be a tuxedo. Is their dress a little off? There's a section for makeup, a reminder to look at people's exposed skin, and to look for any scars, and a place for any medical observations. Your checklist might look different. You might think that the idea of having a checklist for this type of task would get in the way of you using your own eyes and insight, but clinicians do, on occasion, use these checklists to remind them to be thorough and to explicitly state what is not there, because we're very biased towards what is there, and what a checklist will do is we'll say, no, there wasn't any abnormal psychomotor activity. In other words, the checklist reminds us to notice what's absent, something our brain often needs to be reminded to notice. This is also where we would notice whether someone used a cane or not. So these are some checklist examples for appearance and behavior, what you might see in an actual clinical description once an individual clinician has made their observations, maybe with the scaffolding of a checklist, maybe not, would be something like this. The patient presents in tattered clothes, all of which appear filthy. Her nails are laden with dirt, and she literally has her soiled wig on backwards. She's wearing 2 wristwatches on her left wrist and tightly grasps a third watch in her right hand, which she will not open to shake hands. Her arms and knees moved restlessly throughout the interview, and she stood up to pace on a few occasions. She did not give any evidence of active response to hallucinations. She smelled badly, but did not smell of alcohol. At times, she seemed mildly uncooperative. So there's our clinical description pertinent to appearance and behavior. Now we can move on to thought processes. The checklist approach has us look at things like the fluency of language, the client's ability to understand the language that we use, various features of how the client constructs their speech, the presence of speech errors called paraphasias. So did the client use a word that kind of sounds like the word that they meant to say? So I'll tell you what I did on the deep end rather than I'll tell you what I did on the weak end. Or do they make syntactical types of paraphasias? So hearing and talking are in the same conceptual family. Do they say, I can talk you just fine? A paraphasia that might fall in both camps might be, I can clear you. So that's in the conceptual family of hear, but it's also an auditory paraphasia, because hear sounds like clear. This is also where we evaluate thought content. So what is it that the client is talking about? In the psychiatric interview, this is parceled out as thought content in its own category. And here we're looking for red flags regarding the client's potential risk to themselves or to others. And we're assessing whether they seem plugged into reality or maybe verging on delusional regarding their beliefs about themselves or others. There's a whole lot packed into the thought processes subsection of the mental status exam, especially for the psychologist and psychiatrist. So those were just a few checklist items. The psychiatric interview approach looks in more detail, and we'll look at rate of speech, whether speech is pressured, meaning there are very few gaps between sentences or between topics. We're also looking for tangential thought, the key feature of which being if you have one sentence and it makes you think of something else, and that makes you think of something else, and that makes you think of something else, and you never return back to your original idea or your original topic, then that is tangential thought. If you do go on a circuitous route, but you actually end up back where you started, so you kind of make sense of your tangent, then that's called circumstantial thought. We're also looking for loose associations, or what's also called word salad. And like the Freudians before us, we're still looking for what tends to be called thought blocking. If a client stops talking, well, maybe what they had been talking about has deep unconscious significance, or maybe they were interrupted by a hallucination. Either way, their thoughts being blocked or interrupted could have clinical meaning or significance. We're also looking for ruminations, obsessions, compulsions, and whether the individual at any point seems to be responding to something that is not there. So there's a lot happening in the thought processes subsection of the mental status exam. What this might end up being written up as in a clinical description is the patient demonstrates a moderate pressure in her speech. Note that this means she's not pausing, as if what she's saying does not have punctuation. It just words at the end of one sentence and the beginning of the other are ran through just the same as the words between or in the middle of sentences. Accompanied at times by loud outbursts. Even her baseline speech is slightly louder than normal. Her speech is moderately tangential, with rare instances of a mild loosening of associations. In other words, what she says in sentence 2 and sentence 3 appear to have very little to do with what she said in her first sentence. Continuing with the clinical description, without thought blocking or illogical thought. So she doesn't appear to stop mid-sentence and never return to her original ideas, and she doesn't appear to present any reasoning that is patently wrong where she demonstrates reasoning. So those are her speech characteristics and thought process. Moving on to thought content, the patient appears convinced that if the watch is removed from her right hand, the world will come to an end. So there's a clear delusion. She proceeds to relate that, consequently, she's not bathed for 3 weeks. She also feels that an army of rats is following her and is intending to enter her intestines to destroy, quote, my vital essence. She denies current suicidal ideation or plans. So why do we include that in the report? Well, firstly, to show that we inquired, and secondly, to remind ourselves of what was not present. She denies violent or homicidal ideation, also denies any thoughts of self-mutilation, without ruminations, obsessions, or compulsions. Okay, so that's thought content. Moving on to perception. The patient denied visual, auditory, and tactile hallucinations, and any other perceptual abnormality, such as illusions. But we write it down to remind ourselves that we asked and to show that we're doing our due diligence with regards to the mental status examination. Next, mood and affect. Recalling that mood is how the client reports themselves to feel, and affect is what we observe in terms of their actual emotional responses to things. Checklist examples. How do you feel? What is your current mood? Please describe it to me, and I will write it down faithfully. I will also be observing you. And if you say you are very happy, but your face says that you're worried or scared or anxious or angry, I will also be circling those words in front of me. I will be also assessing whether you seem to display the range of affect that is normal. I may observe restricted, blunted, or flat affect. In other words, not much movement. And then I might look at how much you move within this range, or how often. So if I note emotional lability, that means that your affect or feelings are changing very much over the course of the interview. Maybe certain topics very easily get you excited, but that excitement leads to other emotions. If you are emotionally all over the map, this is where I would note that. And if you say you're telling me a sad story, but you don't appear sad, or if you say you're telling me a funny story, but you don't appear amused, then this is where I would note that you appear to be demonstrating affective incongruity. And again, I don't necessarily know if any of these observations are going to lead to anything in terms of diagnosis or grist for future discussions. I just know I need to make sure to look for these things, their presence or their absence, so that I have the option of using it later in case it turns out to be useful. A clinical description for mood and affect. When asked about her mood, the patient angrily retorted, "My mood is just fine, thank you." Throughout much of the interview, she presented a guarded and mildly hostile affect, frequently clipping off her answers tersely. When talking about the nurse in the waiting area, she became particularly suspicious and seemed genuinely frightened, without tearfulness or lability of affect. Again, we note down what is absent. This is what the checklist gives us. It reminds us to make note of what is not there. Next, intellectual functioning. The most basic checklist approach here is just to generally bin someone in terms of the level of the language that they use. So do they speak more like a book or more in slang or idioms, or is it some kind of blend or normal for the circumstance use of language? Normal usually meaning that they try to match your level of formality, and this is just for observation of the meeting. How did they speak in this initial meeting? They could be putting on more formal airs, or they could be someone with multiple PhDs who prefers to speak in slangy and idiomatic phrases. We're not circling what type of person they are, just how they spoke when we first met them. Most clinics will have a kind of short list of questions that we can ask individuals for a mental status exam. Similarity questions might be, in what way are a pen and a pencil alike? How are they the same? And an example of a good abstract or conceptual answer to that question would be, well, they're both, tools with which humans write. Okay, great. A more idiosyncratic response to that might be, either one of them could be used to stab you. And a simpler or more concrete answer to that question would be, well, a pen and a pencil aren't alike. They're not the same. A pencil is a pencil, and a pen has ink, and it's a pen. This question is not revealing their quality as a person or the nature of their soul or anything. You're just kind of getting some relevant information for how they address problems. And usually the shorthanded description we use when we're assessing intellectual functioning is we're seeing how prone to abstraction or conceptualization a person tends to be. We might ask the individuals things from their past that are maybe in their chart or their records, things that they should know. See whether they can answer these questions and whether they're comfortable trying to answer these questions. We could also do various delayed recall types of tasks. So I might say, listen to these 3 words: blue, book, sun. Can you repeat them back to me? Blue, book, sun. Yes. Okay. Now, anyway, moving on, and then I ask some other questions, and then I come back a couple of minutes later and I say, okay, what were the 3 words that I said that you said back to me? And we'd see whether the person can remember them. And for immediate recall, you could just do letter numbers. So I'm going to say some letters and numbers, and then I want you to say them back to me, saying the numbers first and then the letters. A12C. 12AC. Great, good work. Now, if we're serious about assessing intellectual functioning, we have tons of great IQ and developmental related tests that we could run to do a very good job of assessing the individual's ability to abstract, to recall, to translate, to manipulate, to complete, to order, to copy, etc. But in most cases, we're not going to take the hour to hour and a half that it takes to run an IQ test. We're probably just going to do 3 or 4 little immediate recall and delayed recall types of tests, and infer the rest from the language and concepts that the client tends to use. And the checklist would also probably have an option that would note that, for example, if we have somebody who seems to be very high functioning in terms of intelligence, we might note that they are status incongruent if, despite this apparent intelligence, they do not appear well put together or well dressed, or to be, by appearances, succeeding. The psychiatric interviewing approach combines intellectual functioning with sensorium and insight, so we'll move on to sensorium, which tends to be pretty simple. We ask, who are you? Do you know who I am? What is the time and date? And where are you right now? And if the client can answer all of 3 of these questions, they are said to be oriented times 3. If you're lucky enough to live to be very old, so that they need to start checking you for dementing, then you'll get very good at, in doctor's offices, answering the question, what is the date? So you may have no difficulty with orientation, or you may make some errors, and you may make what's called a normal error, or you may make what's called an abnormal error. So if I ask you, what is the time and date, and you're off by 1 or 2 days, or 1 or 2 hours, well then that's a normal error. It's not correct, but it's a normal error. If you tell me that it's 1997, well, that is an abnormal error. You've made a serious mistake. Same with place. Say you're at a clinic and you get the specific name of the clinic wrong. Well, that's a normal error. But if you say you're at the airport, then obviously that's an abnormal error. Next, can you get your own name and your own past or present occupation correct? Here I would just circle the one that you got incorrect in this checklist approach. And do you know why you're in the clinic? So for sensorium, cognitive functioning, and insight, here's your clinical description example. The patient appeared alert with a stable level of consciousness throughout the interview. Indeed, at times she seemed hyper alert and overly aware of her environment. She was oriented to person, place, and time. She could repeat 6 digits forward and 4 backwards. So there's your immediate recall. She accurately recalled 3 objects after 5 minutes. Not bad. Other formal cognitive testing was not performed. Her insight was very poor, as was her judgment. She does not want help at this time and flatly refuses the use of any medication. So that last would be a reference to insight. So the mental status exam overall helps us organize our observations, which helps us to focus further attention, individualize what we're going to do to this unique client's needs, avoid what's called the what you see is all there is bias, i.e. make note of what is not there, and start a record for further study, rather than just relying on our rather malleable and suggestible memories. In most cases, the type of reliability we're after in psychology and psychiatry is inter-rater reliability. In other words, if a bunch of different psychologists and psychiatrists look at the same case, will they come to the same diagnosis? If yes, then we have good inter-rater reliability. We lack this for things like major depression and anxiety, but we do have good inter-rater reliability for things like autism and schizophrenia. But of course, you can have good reliability without having a necessarily useful or good tool. An example I like to give is I'll hold up a pencil and then I'll say, this is my test as to whether I am the Queen of England. If I let go of this pencil and it falls downwards rather than upwards, then I am the Queen of England. And then I drop the pencil and it falls down. And I say, so I guess I'm the Queen of England. But wait, I can see you're not convinced yet. I'll show you that my test is reliable. I'll run it again. And then I drop the pencil again, once again confirming that I'm the Queen of England. I have a very reliable test. No matter who holds the pencil and drops it, the pencil says by falling that I am the Queen of England. I have a very reliable test. It doesn't mean it has anything to do with the actual question that I'm using it to answer, which is whether or not I am the Queen of England. In other words, I have a reliable test. It consistently gives me the same result, and it would if other people dropped the pencil as well. But I just don't have a valid test. In other words, it has nothing to do with the actual question I'm trying to answer. Having a valid test requires having a reliable test, but having a reliable test does not mean that you have validity. Validity needs reliability. Reliability doesn't need validity. Reliability on its own is no guarantee of anything except similarity. What we want is validity, correspondence with reality. Whether our test is measuring something important or useful is going to be determined by what it can predict or influence.
When dealing with substances, knowledge of the psychoactive effects of substances and their withdrawal symptoms is both helpful and necessary. I would advise taking a course in psychopharmacology, which I have also taught, for a deep understanding of what is motivating and demotivating people just beneath the skin. It provides a new level of insight that is necessary for clinicians, especially clinicians with very little experience imbibing substances themselves. Here are my answers to the additional clinical description questions. And here is your homework. Consider something about yourself you would like to change. A health behavior, an attitude, a skill or skill level, development of knowledge, taking control, or self-organizing, anything you could file under self-management. With that something in mind, what is the presenting issue? What is the specific thing to change? How common is this issue? What is the chance of success on your journey to change? What do typical attempts to change look like? And I put this last because it's not necessarily as important as a lot of psychotherapeutic paradigms might treat it to be. What is the origin story of the thing you want to change? On any journey of change, these are important contextualizing factors, and making some honest estimates of these things can be both difficult and enlightening. I think we have now gotten the basics out of the way so we can get deeper into more addiction-specific waters. Co-occurring psychiatric disorders coming up next. Stay tuned.